Greeting everyone. I am Dr. Deependra from Conceptual Orthopedics, and I welcome you all in today's connect session with Faheem sir. And today sir is going to discuss another, I think, very important topic from pediatric orthopedic point of view is growth modulation. So I think this talk will be very useful to all of you. So without any more delay, I welcome you sir on the board, and I request you to start your presentation. Now it's over to you, Dr. Faheem sir.
Thank you, Dr. Deependra. Okay, so today's class is going to be on growth modulation. So before we delve into the topic of growth modulation, we initially need to know why this was basically required. Okay, so generally pediatric orthopedicians or even general orthopedicians are often consulted to evaluate and manage deformities of the lower extremity. So they can be sagittal plane, coronal plane, or rotational deformities. Now, why are they important? Because when left untreated, they can have lifelong adverse impacts upon the gait and also upon the spine. So initially, all of these used to be corrected with the corrective shoes, orthotics, bracing, physiotherapy. But now, with the advent of safe and sound surgical techniques, the surgical management for indicated cases has increased. Now, since 1933, Femister introduced the concept of open epiphysiodesis for the management of angular deformities and limb length inequality. Now, this used to be an open procedure and it used to be a destructive procedure where the physis used to be completely damaged. With the advent of fluoroscopy, the method became relatively minimally invasive. Okay, so even though it became minimally invasive, the physis was still completely destroyed and the reversibility of the procedure was not present. So the physis used to be completely damaged and no more growth was possible at that physis. Okay. Now, because this was not reversible, open or percutaneous epiphysiodesis had to be delayed until the child was adolescent, because you had to perfectly time the remaining growth at the physis, because if you do it too early, the deformity can overcorrect, and if you do it too late, the deformity can undercorrect. So that is why this non-reversible procedure had to be timed perfectly so that you do it, and once the correction is achieved, it should not go into either under or over correction. Okay. The problems of deciding when the child will be skeletally mature and of the compliance of the parents and also the follow-up made this open or percutaneous epiphysiodesis little cumbersome to do. Okay. The same drawbacks of open or percutaneous epiphysiodesis are electrical physiodesis and radiofrequency ablation. All of these are permanent and irreversible. Okay. So when we come to progressive conditions such as Blount's disease, non-nutritional rickets, genu valgum, all of these are considered progressive, and osteotomies are still gold standard for these conditions. But the disadvantages of osteotomies are an open procedure, relatively more blood loss, neurovascular compromise, immobilization, under or overcorrection, malunion, or non-union. So the children generally take 1 or 2 months off their school or play group for this osteotomy to heal. Okay. Problems: the cost, the immobilization, the weight-bearing restrictions, the longer scars or the larger scars, and more difficult hardware retrieval was present along with osteotomies. Okay, so all of these drawbacks bring us to the advent of growth modulation. Okay. So growth modulation meant that you could modulate the growth. When you required the deformity to be corrected, you could do the growth modulation, and when you felt that the deformity is corrected, you could take it off. So you could modulate it. It's sort of like watching TV, where you liked something, but then you suddenly got bored, so you changed the channel to something else. Okay, so this is something like that. So this is a temporary reversible epiphysiodesis, which is cost effective and does not have many of the problems that osteotomy or open epiphysiodesis has. So this was first described by Haas, which was done in animals and then later in humans. Soon after that, the popularity for this procedure came from Blount, okay, who in 1947 made the Blount staple for the correction of angular deformities and limb length inequalities. Now, since the physis is a dynamic organ or tissue, and the forces of growth are so powerful that the Blount staple generally used to fail. It either used to bend, break, or migrate. Okay, and this is because in really young children, the physis grows so fast that the staple is unable to hold back the forces of these growth. Okay, so the use of multiple staples also failed consistently to address these problems. So staple removal also proved challenging, resulting in even bone loss in that area. And if there is bone loss in that area, which is around the physis, then you're damaging the physis, and maybe the reversibility of this technique could be questioned. Okay, so there came the concept of an extra periosteal plate, which serves as a tension band plate, which was developed in 2002 and introduced in 2004. So Peter Stevens is given the credit for this. So they come with 2 holes and 4 holes. As you see here on the right hand side, you have a quad plate and a 2-hole plate, and they all have a hole in the center. So we'll come to, of course, is to center it over the physis. Okay. Now the quad plates are more stronger plates compared to the dual hole plates or the 2-hole plates. Okay. Now it is not critical which implant one selects. Okay. It is the tension band principle that counts. So this is the Hutto-Volkmann principle, which tells that if there are compressive forces on the physis, then the physis in that region will not grow. Okay. When there are compressive forces over the physis, tension band plate, but remember, avoid using a locking plate because this rigid construct will predispose to implant failure. In resource challenge conditions and where you do not get these plates, you can also use the 2-hole reconstruction plate, or a 1/3 tubular plate can also be used. Okay. So the relative disadvantages of using a reconstruction plate is that they're relatively bulky and they're stiff. They will not reverse bend when compared to the real tension band plate. Okay, sometimes in heavier children, you can use a quad plate, especially when you're trying to do this for the Blount's disease. But remember, when you're using a heavier plate, they are more heavy and they will not bend easily. So this reverse bending will not take place. Okay, so remember, there is a lot of different types of devices which are present, but all of them will give you the same thing. Okay, it does not matter whether it is 2-hole, 4-hole, whether it is stepped off, bent, whether it is which color the plate is, or whether it's stainless steel or titanium. Similar, there is a lot of controversy regarding what you should use, but as long as you're using a tension hold plate, you should be good in. Okay, any plate which is flexible and permits a differential growth can work. Okay, now apart from the growth modulation with the tension band plate, there is a growth modulation which was popularized by Mitesio.